The head and neck examination is not intended to be diagnostic. It is only a screening examination. Because cancer is more readily treatable when it is identified at an earlier stage, any atypical or pathological findings should be further investigated or referred as deemed appropriate by the clinician. The steps that we demonstrate in this video represent one possible sequence for performing this examination. You may choose to perform your examination in another order, as long as you assess each area and are consistent in your examination. The head and neck examination is performed in two phases, beginning with an extraoral examination. Personal protective equipment, including gloves and masks, should be worn during this examination. Start by observing a frontal view of the patient's face. A healthy patient's face should be symmetrical and without any obvious skin or eye conditions. Ask the patient to smile and observe lip movements. Standing in front of the patient, bilaterally palpate the temporal muscles from their origin on the cranium inferiorly to just below the zygomatic arches where the mandibular condyles articulate with the temporal bones. The lateral aspects of the condyles can be palpated just anterior to the tragus of the ear. While palpating the condyles, ask the patient to open and close several times. Feel and listen for any clicking or grinding of the joint during articulation. Note any deviation of the mandible upon opening or closing. Finally, ask the patient to open as wide as they can without causing themselves any pain. The mandible should open a minimum of 45 millimeters. Moving away from yourself, palpate along the maxillary sinuses, feeling for any swelling. Ask the patient to report any tenderness. Bilaterally palpate the masseter muscle. The muscle should be soft, free of nodules, and not result in pain upon palpation. Ask your patient to turn their head to the left. This will expose and extend the right sternocleidomastoid muscle. Palpate along the muscle to feel for any swollen lymph nodes. The muscle should feel evenly firm and smooth to palpation. The patient should not feel any discomfort. Finally, have the patient turn to the right and repeat the process on the left side. Return the patient's head to face forward. Palpate along the inferior border of the mandible towards the chin. Around the angle of the mandible, you will feel the submandibular salivary glands. These should be slightly firm upon palpation. Note any discomfort or identifiable lymph nodes. Next, palpate the thyroid gland for symmetry and tenderness. Finally, retract the earlobe and palpate the postauricular lymph nodes. Visually inspect the area behind the ears as well as the top of the ears for any skin lesions. Repeat the process on the other side. At this point, the extraoral examination has been completed and a review of the steps are presented here. To transition to the intraoral examination, change your gloves, ask the patient to put on a pair of safety glasses, and recline the patient's chair slightly. Before beginning the intraoral examination, ask the patient if they have any lesions or soreness that they are aware of. During the examination, if any abnormalities are encountered, a periodontal probe may be used to measure lesions for documentation. Begin the examination by palpating along the upper lip and visually examining the mucosa, mucolabial fold, gingiva, and frenula. Repeat the process on the lower lip. Both lips should feel uniformly muscular and free of nodules. The oral tissues should appear wet with saliva and exhibit a pinkish hue. Retract the left cheek and visually examine the left buccal mucosa. The parotid duct empties saliva into the oral cavity on each side of the cheek and may be visible adjacent to the upper second molar. Repeat the process on the right side. Ask the patient to open widely and visually examine the hard and soft palates. Use the hand mirror to visualize the palatal surfaces immediately behind the upper incisors. With the aid of a tongue depressor, visually inspect the tonsillar area. The palatine tonsils, if present, should not appear swollen and the crypt should be free of discharge. Ask the patient to place the tip of their tongue on the roof of their mouth and open wide. Visually inspect the ventral surface of the tongue, the lingual frenulum, and the floor of the mouth. Extensive vasculature is normal in this area of the mouth. Unfold a 2x2 piece of gauze and refold it into thirds along the length. Ask the patient to extend their tongue and wrap the tongue with the gauze. Gently pull the tongue to the side and examine the lateral borders of the tongue. Many patients find this portion of the exam to be uncomfortable. When finished, give them a moment to relax, remoisten their tongue, and swallow before moving on. Palpate along the depth of the mucobuccal fold, feeling for any swelling. Ask the patient to report any tenderness or discomfort. Repeat the process on the upper jaw. Gently dry the buccal mucosa with a piece of gauze. Place one hand onto the cheek anterior to the patient's ear. With the other hand, retract the cheek and palpate the parotid gland through the cheek. Saliva should express from the parotid duct. Repeat the process on the other side. For the final step of the examination, place one hand on the submandibular gland near the angle of the mandible. Palpate the submandibular gland through the floor of the mouth below the tongue. Move both hands together as you palpate, moving to the interior. The oral cancer screening is now complete, and you may enter examination notes into the patient's records. A review of the intraoral examination steps is presented here. Other than the small lip abrasion, our demonstration patient was healthy and asymptomatic. Some patients, however, will present with some symptoms or clinical signs that warrant further investigation. Among the more common clinical findings are leukoplakias and erythroplakias. These are descriptive terms for white and red lesions present on the oral soft tissues. Some patients may report difficulty with chewing or swallowing, a sore throat, the feeling that something is caught in their throat, numbness in or around the mouth, hoarseness, or a change in their voice. If any of these signs or symptoms persist for longer than 2 weeks, further clinical investigation is indicated. In a dental setting, the head and neck examination is typically performed as a portion of an initial comprehensive examination and at periodic recare examinations. Clinical signs from this examination are coupled with patient interview data to aid the clinician in screening patients for the presence of oral cancer or identifying lifestyle factors that may increase the patient's risk of developing oral cancer. The two single biggest risk factors for developing oral cancer are excessive alcohol and tobacco use, especially if used concurrently. Unavoidable risk factors are age and gender. Risk increases with age, and men are about twice as likely to develop oral cancer. One way patients can lower their risk of developing oral and pharyngeal cancers, as well as most other cancers, is to maintain a diet rich in fruits and vegetables. In addition to screening for oral cancer, this examination also affords the clinician the opportunity to get a picture of the patient's overall oral and dental health. While looking through the mouth, you can quickly assess the patient's dentition. Starting at around age 2, children should have all 20 of their primary teeth. By around age 7, children start the process of losing their primary teeth and replacing them with permanent teeth. By about age 18, up to 32 permanent teeth should be in the mouth. Complete dentition usually only includes 28 teeth because some third molars or wisdom teeth do not develop or they're extracted due to impaction or infection. Looking at the individual teeth, they should be a glossy whitish color. Early signs of caries or decay are chalky white areas that aren't as shiny as the rest of the tooth. As we can see in this image of a child's mouth, as decay progresses, the tooth surface takes on a yellowish color and a depression or cavity in the tooth may be present. In severe cases, gross decay will be a brownish or blackish color. Regular dental visits are important because they can help spot oral health problems early on when treatment is likely to be simpler and more affordable. Visiting a dentist is also important because some diseases or medical conditions have symptoms that can first appear in the mouth. Some of the signs and symptoms that indicate referral to a dentist are listed here. Thank you for your time, and we look forward to seeing you in the clinic.